Dissociative disorders are psychological conditions characterized by disruptions in memory, awareness, identity, or perception. These involuntary disruptions act as protective mechanisms, often triggered by psychological trauma, stress, or intoxicants, though sometimes they occur without any identifiable triggers. Such disorders, listed in the American Psychiatric Association's EDSM-5, include dissociative identity disorder, dissociative amnesia, and depersonalization, derealization disorder. In dissociative identity disorder, the individual alternates between two or more distinct personalities, with each personality having impaired recall of the others. In severe cases, the main personality is unaware of the other personalities, even though the alternate egos are often aware of the others. Dissociative amnesia, considered the most common of dissociative disorders, involves the loss of episodic memory, often in response to distressing or traumatic events. The onset of this condition can be sudden or gradual, and the duration varies from minutes to years once separate. Dissociative fugue is now included under this category. Depersonalization. Derealization disorder is characterized by periods of feeling detached or disconnected from oneself or one's surroundings, while maintaining the understanding that these perceptions are not grounded in reality. The EDSM-IV category of dissociative disorder not otherwise specified has been divided into other specified dissociative disorder and unspecified dissociative disorder, catering to dissociative instances that deviate from the typical categories or which are temporary in nature. These disorders, according to the ICD-11, often develop as coping mechanisms in response to psychological trauma. They're common among those exposed to long-term physical, sexual, or emotional abuse in childhood, though one-off traumatic events such as warfare or the loss of a loved one can also trigger them. Most importantly, dissociative disorders, particularly dissociative identity disorder, should be viewed just like any other psychological disorder, devoid of any extraordinary or supernatural connotations. The approach towards examining and treating these conditions must be grounded in practical understanding and professional medical principles. The narrative explores dissociative disorders, particularly dissociative amnesia and depersonalization, derealization disorder, focusing on their causes, treatments, prevalence, and diagnostic methods. Psychological trauma, especially childhood abuse, often triggers such disorders, however. It's not an absolute in every case. The primary therapy method applied includes psychotherapy counseling and psychosocial therapy. In certain cases, the medication pentothal may help in restoring lost memories. The duration of the disorder's episodes could range from a few minutes to several years. Depersonalization. Derealization disorder, though not as directly connected, often correlates with childhood trauma as well, particularly emotional abuse or neglect. Stress, like the sudden death of a loved one, can also trigger it. The therapies for this disorder align with those of dissociative amnesia, with no specific drug treatment. Dissociative disorders have a variable prevalence, with an incidence of about 10 in the general population and as high as 46 in psychiatric inpatients. Diagnostic tools supporting the identification of these disorders include the Dissociative Disorders Interview Scheduled (DIs) and the Structured Clinical Interview for DSM-IV Dissociative Disorders (SID-DRU). Dissociative information such as questionnaires, previous doctors, records, and input from relatives can be useful in reaching the diagnosis. Such disorders are commonly seen in outpatient settings and within low-income communities, as one study indicates an occurrence rate of approximately 29 among poor urban outpatients. The diagnostic and therapeutic strategies for dissociative disorders remain a challenge owing to the historical concept of hysteria and differing diagnosing systems like DSM, IZ, and IC. 10 significant difficulties are also observed in diagnosing children and adolescents, with the need for adjusted diagnostic tests for these age groups. An alarming issue in health and criminal justice today pertains to the misdiagnoses of patients with dissociative disorders. These individuals are more prone to frequent hospitalizations and suffer from increasing disability rates due to treatment deficiency. In forensic analyses, there's a significant concern regarding the patient potentially falsifying symptoms to avoid ramifications. The prevalence of such disorders, such as amnesia, has been found to be undeniably prevalent among young criminals. For instance, one of young lawbreakers reported having complete amnesia regarding a violent act, while 19 claimed partial memory loss. The occurrence of dissociative disorders worldwide remains unclear due to differing cultural perceptions regarding human emotions and cognitive processes. However, studies indicate that stressful experiences such as abuse or loss during childhood contribute significantly to dissociative disorders. Sadly, such symptoms often remain unnoticed or are misunderstood in children and young adults. Recent research has brought about a slight shift in this by increasing awareness of these disorders in children. Notably, this implies that such disorders are prevalent across cultures, underlining the universality of the issue. Identifying dissociation symptoms in children can be complex due to several reasons, including the children's inability to express their experiences, overlooking or hiding neglectful behaviors by caregivers, subtle symptoms, and misinterpretation of the memory, mood or concentration issues as signs. Of other disorders, Beacon House, a noteworthy resource organization, emphasizes that children commonly use dissociation as a coping mechanism during traumatic experiences. Dr. Shoshana Lyons amplifies this viewpoint by stating that such children continue to deploy dissociation, often without realizing it, even in non-threatening situations. Recent studies are channelizing efforts to enhance understanding and diagnosis of dissociation in children. They focus on unveiling the neurological symptoms of dissociation, which are often linked to childhood trauma, to improve the recognition and treatment of these disorders. Furthermore, experts argue that observing disorganized attachment, DA, could direct clinicians towards potential dissociative disorders. A 2008 article by Rebecca Seligman and Lawrence Kiermaier substantiates this by stating a significant correlation between traumatic events in childhood and the ability to dissociate or depersonalize. They further propose that those capable of deploying dissociative strategies have an overarching coping mechanism for stressful circumstances. The theme of numerous controversies surrounds the concept of dissociative disorders, DDED, in both adults and children. One major point of contention is the etiology or cause of dissociative identity disorder, DID. Key arguments pin the onset of DID to either childhood trauma and disorganized attachment or physiological responses, such as heightened blood pressure and alertness. Meanwhile, another debate questions if dissociation as a defense mechanism and pathological dissociation differ more in terms of quality or quantity. Such manifestations of dissociation could vary from commonplace experiences to symptoms related to post-traumatic stress disorder, PTSD, or acute stress disorder, ASD. Even though the DSM-5 workgroup once examined grouping dissociative disorders with other trauma stress disorders, these disorders were eventually placed in a subsequent chapter to highlight their close connection. Research suggests that contemporary or recent trauma could lead to an alteration in people's evaluation of their past, often triggering dissociative states. Still, cognitive science experiments challenge this dissociation construct, which continues to be based on early dissociation theories. The assumed link between childhood trauma abuse and dissociation also raised eyebrows. Some argue that the connection between trauma abuse and DDES seems to be largely Western, but that in non-Western cultures, dissociation might be a standard psychological capability. An alternate model establishes dissociation based on the recent discovery of a fluctuating sleep-wake cycle's impact on cognitive failures and difficulties in differentiating reality from fantasy. Cultural perspectives from the West versus non-West around DID and the causes add to the debate surrounding this subject. DID was initially considered specific to Western societies, until studies demonstrated its universal occurrence. However, not much anthropological work on DD relating to the West-perceived possession syndromes had been done nevertheless, while anthropologists categorized dissociation differently in Western and non-Western societies. Some universal characteristics of DD are evident. For instance, while non-Western shamanic rituals might have dissociative elements, many Western practices, such as being possessed by the Holy Ghost, share similar trance-like qualities.